My name is Stephanie. I'm a fourth year student at the University of Iowa, Carver College of Medicine. And today I'll be doing a case report. Well, you guys will be mostly doing it. I'll be leading it, but like a case presentation on a pediatrics case with a child that presents with like fever and then adenopathy. And so this little meme is kind of like joking at what it's like to be on pediatrics rotation or just be a pediatrician in general. I feel like you always have to carry around stickers or lollipops or something like that to make the kids feel, safe, and not everyone enjoys going to the doctor as a child. So I know I didn't. I always looked forward to having the lollipops at the end. All right, so here's the session outline. We'll just go through the case and then we'll get more information as we go along. And you're welcome to fill out your SOAP note throughout. And then at the end of the presentation, there will be a quiz and then an opportunity to also provide feedback. Okay, so here's just what the SOAP note looks like. You should have access to this. And again, if you don't, just let me know. And then just let's see, looks like we might have a couple new people, maybe. So if you want to toss in the chat or make an X on the map from where you're from, that's always fun to see. So I'm from Iowa, so I'm like kind of near the border right here. Okay, got some Michigan, great. Massachusetts. Can always remember the Massachusetts because it looks like, they're flexing or whatever. This great. Awesome. Well, welcome everybody. Again, I thank you guys for coming and participating. It's always fun. Okay. Let's go to the next one. Awesome. So here is our case. If you guys want to just read the first part in your head, that is great. And then we'll talk about it a little bit. Okay. So I have a question for you guys. Do you know what temperature usually classifies like having a fever? Sorry, I'm erasing these guys. Okay, let's see here. 100, yeah, around 100, yeah. It really just depends. So usually it's like 104 degrees Fahrenheit, which is like around 38 degrees Celsius. Now, of course, that can depend on like your patient population. If you have a patient that's like immunocompromised, they can't really mount fevers as well. And so their threshold might be lower. Additionally, it depends on like where you put the thermometer, is it in your mouth or is it an axillary temperature or rectal temperature? That can also, change the cutoff as well. But in general, we classify a fever as greater than 100.4 degrees Fahrenheit. Okay. And then what do you guys think the significance is of this child having like a negative throat culture for group A strep? So group A strep, usually when like children especially come in, the most common cause of like pharyngitis and like sore throat, things like that is group A strep. Strep throat is what we call it in layman's terms. So patients when they come in, children, they'll get like a rapid strep test. If those results are negative, you have to follow that with a culture, like a culture, the actual swab and the sample to see if anything grows. Because the test, if it's negative, it doesn't necessarily mean the person doesn't have strep throat, right? The rapid test. So you always have to follow that up with a culture. Now, if your rapid test is positive, then you don't need to follow that up with a culture because you'll just treat the patient. But in this case, the test was negative, so they went ahead and did the culture, and then the culture came back negative too. So this person, this child, the Keisha, she does not have strep throat. Okay, so both of those are good for ruling out together for ruling out strep throat. Okay, all right. So what other questions do you want to ask Keisha and her mom? What are some other questions to consider about the history? And here's like our depiction of the old cards, like some of the things that we like to ask patients to get more details about what's been going on. So like when it started, if there's pain or anything like that, where it's located, how long, if things make it better or worse, timing, that sort of thing, severity. So let's see. So I think it's important to ask if the fever is like similar to those that she's had in the past, if she's had fevers in the past. If she's been, importantly, if she's been around any sick people, right? Because if she, has a sibling and your sibling has had the flu or something, then chances are if you feel crappy, you might have the flu as well. So that's important to know. Vaccinations is very important too especially for pediatric patients, right? That can change our differential essentially, because if they're vaccinated, you have a lower likelihood of getting some sort of virus that we vaccinate against, for example, like measles. Any additional symptoms that they're having, and then behavioral changes too. For pediatric patients, this is especially important. And that's because many times, younger kids can't really tell us what's going on. They can't describe it maybe the best. And so noticing if the parent or the, child care worker or the teacher notices the kid's been like more irritable, just not acting like themselves, that can be a clue that they don't feel well. And then in general, just always asking our patients about the past medical history, if they've had any surgeries. And then for this patient, especially because she's had this persistent fever for multiple days now, I think it was 6 days, have they tried anything for the fever? Any Tylenol, any ibuprofen, and does it help? How quickly does the fever come back? That's important to ask as well. And then questions about the rash too, getting more information about the history of the rash. Okay. So you ask those questions, and I'll give you some moments to read this and pick out some important information with her. All right. So what are some things in here that stick out to you? What are some pertinent like positives, maybe pertinent negative symptoms? What do you guys think? Loss of appetite. Yeah, great. That's one to know for sure. And I think that a good point too is that they're making is that the mom has been pushing fluid. So hopefully that even though she's not eating as much, she's still well hydrated. So that's important to know. We also learned that they've been trying Tylenol and ibuprofen, and it does help a little bit, but the fever comes back, which is never a really good sign, right? The fever should not be going on for this long. And then now, she has this new rash as well. And then she also has some redness of the eyes and the tongue. So that's kind of what we got from this, the rest of these details here. Okay. And so taking a look at her, past medical history and family history. What do you guys think is one of the most important parts of the past medical history that we're given for this patient? Yeah, she's had her upper respiratory infection in the past, exactly. And then two, knowing that she's up to date on all her recommended immunizations, right? Because that might change our differential to think that, she's less likelihood for getting certain infections if she's been immunized against them. But yeah, otherwise a generally healthy child, it seems. And then no recent travel, and she does attend preschool. But I think it said in the previous that the people at her preschool were not sick. So, okay. All right. So we've got basically a fever and that's been persistent, and we've got this rash, now this new rash, and then some redness of the eyes and of like the oral cavity and that sort of thing. So when you think of fever and a rash in people, the pediatric patient population, what are some like life-threatening causes or common causes of these symptoms together? Can you think of any diseases that present with like fever and a rash, or maybe one or the other, whatever you guys can think of? Chickenpox, great. Yes, that is something that certainly can present with like a rash, like those vesicles that are itchy. You can also get a fever with that. RSV, yeah, RSV is like, especially this winter, it was horrible, right? Respiratory syncytial virus. It's like can cause, symptoms similar to like the upper respiratory infection. I'm personally not sure if that can present with a rash, but I mean, it's possible, right? But certainly with the fever in this population, we'd be worried about something like RSV. Great. Anything else? What if I told you what is a life-threatening cause of like a fever and a rash? If I told you that like the patient's neck was also really stiff, and they were having headaches. like an infectious disease, like that can cause meningitis or inflammation of the meninges of the brain that can be very, very serious and should always be on our differential when we have like a fever and a rash. Okay. So let's look at just some of these. And, fever and a rash is very non-specific, right? There's lots of causes of a fever and a rash, but some of these to look and to note are some common non-life-threatening ones that include different viruses. We'll talk about this viral exanthems that it's like up here. I have it on the next slide. But these viruses such as like roseola and parvovirus, measles, varicella, all of those can cause fever and a rash. You also see scarlet fever, which is caused by group A strep, most commonly. Lyme disease, just irregular cellulitis. And then some life-threatening can't miss ones are like this staphylococcal scalded skin syndrome. That's a mouthful, but it's basically a skin condition where you get like peeling of the skin, and it's due to a severe Staph aureus infection. Meningococcal disease, that was the meningitis I was telling you guys about. So if they have, neck pain too, irritability, weight loss, the baby's just kind of very lethargic, you're going to be concerned for possible meningitis. You can also have something called Kawasaki disease, which is a vasculitis, so inflammation of the blood vessels that can present with a fever and a rash, and then additional, causes as well. So just for some, extra learning and to understand a little bit more about the common causes of fever and a rash in pediatric patients, here are some of those viruses that can cause the fever and the rash. Now down here, the streptococcal pyogenes, the scarlet fever, for some reason I can't see my mouse, sorry guys. But the second to last one, that is a bacterial infection, but the rest of these are viral infections. And they're common causes that should always be on your differential if you have a fever and a rash. And the clinical presentation for each is a little bit different, but I just wanted to kind of introduce you to all of these. You don't need to know all of them at all, but I just wanted to make you aware that this is something that's really common in pediatric patients that we think of. They're called viral exanthems because it comes with a fever and a rash. And then another thing I wanted to note too is like measles, for example, and rubella and varicella. Remember, all of those are viruses that we get vaccinated against. So since this pediatric patient is up to date on her vaccinations, those are probably less likely. Okay. All right. So what components of the physical exam do we want to pay most attention to with her? And then how do we determine if like there's red flags or if like she needs acute intervention? What do you guys think in general? So usually when we're determining if someone needs acute intervention, it's like, are they hemodynamically stable? So we're looking at things like vital signs. We're looking at things that like their overall volume status. Do they appear dehydrated? Is their blood pressure normal? That sort of thing. Or do they have like orthostatic hypotension where they're like blood pressure and stuff is going to change, whether they're in the sitting or standing position. All of those things can be good. And also just looking at the patient too, right? If they're in severe distress, it's likely they're in a lot of pain or something is going on where they might need acute intervention. Certain red flags for rashes that could be life-threatening include like the stiff neck that goes along with meningitis that I was talking about. If you have hemodynamic instability, if the pain is super, super severe, if there's mental confusion, right, that could, point you to something with the brain as well, or a systemic infection. And if they have sleepiness, breathing problems, persistent vomiting, all of those type of things are red flags. But with our patient, so we took her vitals. So I want you guys to look at the vitals and kind of think about what might be abnormal within this list in a 4-year-old girl. Because our vital signs are actually, just as a hint, kind of, our vital signs are different in pediatric patient, are like cutoffs for what's normal and what's not. Okay, febrile temperature, absolutely. And the pulse is high, yes. So even though this patient is like 4 years old, and so she's expected to have a higher pulse, the pulse for 4-year-olds are usually like 120 to 130 or below. So this is definitely tachycardia. So great. Her blood pressure is actually okay for that age, and her respiratory rate is surprisingly, 25 breaths per minute. We would call that tachypnea, or an increased breathing rate in adults, but that's actually pretty normal for a 4-year-old child. So that just down here is just an explanation of that. So yeah, normal heart rate is usually less than 120 to 130 for these children. And then respiratory rate can even just be normal, even when it's like around 30s, which I always forget about, right? Because I'm used to treating adults. So, okay, so yes, definitely tachycardia and a temperature that we see here with her. So here is the rest of the physical exam. So read through this, and then we'll go through each system and point out the stuff that might be abnormal. All right, so let's start with general. Anything abnormal here? Looks like she just, appears uncomfortable, but otherwise, otherwise generally well nourished, etc. So what about the HENT exam? Lips are cracked, exactly. So some changes to the mucosa there. Do you guys know what bilateral conjunctival injection means? It's basically just fancy phrase for like red eyes. So if you can see this image here, it's just saying that both eyes are red. And they don't note that like there's any purulent drainage from them. They're just both red. And then the tongue is red as well. It looks like the papillae, the little dots on the tongue, as I like to call them, are swollen. So kind of dotted here is what that would look like. And then there is a single lymph node that in the anterior right neck that is enlarged. So this like anterior cervical chain, there's just a single enlarged lymph node. And if you guys remember from a couple sessions back when we did a case on lymphoma, do you guys remember just tell me like if this is worrisome for cancer or not, these mobile, non-fluctuant, and non-tender lymph node. Do you think that is more concerning for cancer or like infection? Infection, yes, exactly. Usually those are tender, but like the fact that it's mobile, it's non-fluctuant, it's not like fixed or anything too. So exactly, great. All right, so lymph it said was normal. Cardiovascular, we've already talked about the tachycardia. Lungs looked normal, and so did abdomen. In the extremities, it looks like we have erythema and swelling of both the hands and the feet. So paying attention to that. And then the skin, they describe the rash as erythematous and macular. So macular, it's a fancy way that we can describe rashes. So a macule is like a spot or a lesion that is less than 1 centimeter usually, and it's not raised. So like when you run your hands over it, it's like, it just feels like skin, right? It's not raised like a, what they would call like a papule or a plaque. Like if you've ever seen people with psoriasis, that skin condition where you get plaques, multiple plaques that can be itchy and things like that, that looks like dry skin, that would be raised and that would be a plaque. But macules are not. Like you can't feel a difference when you run your hand along the skin. So that's important to know too. All right. And so here is an example of what maybe the rash would look like. Okay. Let's go to the next slide. All right. So before we discuss our differentials, so does anybody want to take a stab at summarizing this, or you guys could put it in your SOAP note? So remember a summary, if we're just talking about the way that we present patients to, the rest of our team members, is we talk about the subjective, so like the information the patient gives us. The objective, so anything that is factual, like things that we see on physical exam or maybe any labs we've already done, that's the objective data. And the assessment at the first part of that is your summary, which is like a 1 to 3 sentence, summary of what is going on. And then you'll go into your differential diagnosis as part of the assessment as well. So if anybody wants to list some of the things that we should have in our summary, we can put that in the chat or unmute yourself. All right, I'll just share what we've got here. So, Keisha, our summary of statement would be just that she's a generally healthy 4-year-old female, but she has this 6-day history of fever and irritability. And she had a rapid strep throat culture that was performed 3 days ago and negative. She is now presenting with a persistent fever as well as a new erythematous blanching diffuse macular rash. On exam, she's also found to have mucosal changes of the oropharynx, non-purulent conjunctivitis, erythema and swelling of the extremities, and unilateral cervical adenopathy. So that would be mostly like our summary statement of what we know so far about her. All right. So what is your differential at this point for fever, rash, adenopathy, conjunctivitis? We already talked a little bit about some potential causes, but if you can remember any, or if you come up with any new ones that might be the cause of this patient's presentation, you can put that in the chat. And again, I know that this one is pretty hard because like fever and rash, again, that's pretty non-specific, right? There's many things that could be. All right, Kawasaki's disease. Yeah, absolutely. That is definitely a possibility for sure. And we'll talk more about that. And scarlet fever, absolutely. Both of those actually share a common feature that our patient has. Do you guys know what that is or what we saw on exam that might point you more towards scarlet fever or Kawasaki's? Was there something that made you guys think about that a little bit more? The rash, yeah, exactly, the rash. And then also, do you remember what was seen in like the oral cavity? So there's this thing called what quote unquote strawberry tongue, and we'll have a picture of that. And it's where those, yeah, the swollen papillae, yeah, they become swollen. And it kind of looks like, you know, the outside of a strawberry. And you see that often in Kawasaki's disease and in scarlet fever. You could also see it in toxic shock syndrome. But those two are ones, you know, most commonly in children where we would be concerned about seeing a strawberry tongue. Okay, so here is a more refined differential for fever and rash. I know this is a lot of words. You don't need to know all of these, but this is just thinking about what could be the causes. And I want us to, after we go through this, think about which are our like top two causes, which you kind of already put in the chat. But so adenovirus is just like a viral infection that can cause upper respiratory tract infections, things like that. Probably not as what's going on in this patient. You know, she's not having any cough or upper respiratory tract like symptoms. She does have conjunctivitis, but you know, I'm not really sure you wouldn't see as much of a rash with this either. So maybe a lower on our differential. Measles, we can probably just knock out in general, as well as some of those other viral exanthems that we talked about briefly, like the rubella, the varicella, or the chickenpox. And that's because she's vaccinated, right? So then our other one, so Rocky Mountain spotted fever, it is a bacterial infection actually that is carried by a tick. And so you can get it when you've been like on the mountains, when you've been hiking. It's more common like in the southeastern and south central US. So what happens is you get a fever, and you can also get this rash that classically starts on like the ankles and the wrists, and then it will spread to your trunk. It'll spread more centrally. It doesn't seem like our patient has very many risk factors for Rocky Mountain spotted fever. But then scarlet fever and Kawasaki disease, those two that we talked about. So scarlet fever is caused by group A strep infection. Okay, so the patient will have fever. They'll also get this rash, can be described as like a sandpaper texture sometimes. They'll have the strawberry tongue often. And then the rash often begins at the groin or neck or axilla, and then it spreads to the trunk. Essentially, this is like strep throat with a rash, is what we're thinking, right? And then Kawasaki's disease is inflammation of blood vessels. It's a vasculitis, which that's what inflammation of blood vessels, that's the fancy term for that. And these patients often have a fever for at least 5 days. They have cervical adenopathy, conjunctivitis, a rash, swelling and erythema of the extremities, inflammation of the mucosa tissue, so even the strawberry tongue, etc. And then meningococcemia, that's just something caused by Neisseria meningitis. It's often seen in teenagers or young adults who are living in close quarters, such as like in college or, soldiers that are living in the same, like bunks or like wherever, the soldiers will stay in all their bunks. That can just be a risk factor, is just being in close proximity to people. Okay. So we've already kind of talked about why we think probably these are at the top of the differential. Does anybody have one that would be that they're thinking more so over the other, and why or why not? KD, yeah, and so why are you thinking KD over the scarlet fever, perhaps? So it seems like there's a lot of, symptoms of Kawasaki's. Exactly. Yeah. Somebody had said, so more of the symptoms match is what Isabel said. So yes, absolutely. I agree too with that. And then another thing, do you guys remember when this patient went to the primary care physician, they actually did have a throat culture and a rapid strep test, right? So if we thought that this was scarlet fever caused by group A strep, that's probably less likely in her, because we would have expected to see either a positive rapid strep test and or a positive throat culture. Okay, so those will be positive because it's the same bacteria that's causing this, scarlet fever. Scarlet fever is essentially, like I said, strep throat with a rash. Okay, that's like a easy way to kind of just think of it, I guess. But so we would have expected those tests to be positive. So that's another reason that this is probably less likely too, right? We kind of ruled it out with those tests. So it's likely Kawasaki. All right, great job with that. So, and here's just going over the strawberry tongue a little bit more closely. So here's the little swollen papillae that we saw on the image on the previous slide. But the 3 diseases that these are commonly associated with is Kawasaki, scarlet fever, and toxic shock syndrome, which is why Kawasaki and scarlet fever can often be hard to differentiate against each other. And then that rapid strep and the throat culture can really help, because Kawasaki is a clinical diagnosis mostly. Okay, so speaking of Kawasaki disease, so it's got this fancy term that's also known as, it's mucocutaneous lymph node syndrome, but also known as just Kawasaki disease. And it's an acute inflammatory vasculitis. So vasculitis, inflammation of the blood vessels. Specifically in Kawasaki, those are the small and medium-sized blood vessels. So the small and medium-sized blood vessels in your body also include the coronary arteries, right? The arteries that are supplying blood to the heart. And so in Kawasaki's disease, because it affects those type of vessels, you can be at risk for cardiac complications, which is the most feared complication of Kawasaki's disease. So children can have coronary artery aneurysms. They can even have myocardial infarction. In fact, it's the leading cause of acquired heart disease among children. So it's really serious when you get at this diagnosis, and it's really important to treat quickly so that you don't reach those complications, right? Okay, so the exact etiology or the exact cause of Kawasaki disease is not known, but it is believed to be an autoimmune response to some sort of infectious trigger. They also think that there is like a genetic component, and that's because children of Asian and Pacific Islander descent have like a higher incidence You also see a higher incidence in males than females, but both can have the disease. Excuse me. And then 80% of the patients who have Kawasaki disease are less than 5 years of age at onset. So it's commonly in younger children. And so here are some of the symptoms that we saw in our patient. It's like the red eyes without any discharge, right? No like infection, they're just red. Importantly, a fever for 5 days or more, strawberry tongue, often having a swollen lymph node in the neck, swelling of the hands and the feet, and the redness of them, the rash, and then just irritability and crankiness over. Okay. So just a little bit about the pathophysiology, and you don't need to know like all of the details or anything like that. I think at this stage it's important to just recognize that it is a inflammatory disorder of the blood vessels, okay? But essentially what happens is, we have this is like a cross section of a blood vessel. And we've got like our outer portion and our inner portions. Our inner portions are the intima, then more outer you have the media and the adventitia. And so the intima is made of these things called endothelial cells. And those are like, the media is also made of, smooth muscle cells. So it's like endothelial cells, smooth muscle cells. And then the adventitia, you have loose connective tissue. So usually what happens with Kawasaki disease is like early on, you will get this like destruction and infiltration of inflammatory cells within this intima and media area. And that releases more like inflammatory mediators, which eventually is going to cause the proliferation of cells, which are going to make like fibrous tissue, essentially is what I would want to call it, for you guys to understand, like fibrous tissue. And that can obstruct the lumen of the vessel, and you can essentially get blockage of flow, which is how you would get something like a myocardial infarction. Okay, so that's really like what's going on. It's all of this inflammation and inflammatory mediators that cause like the destruction of this tissue and the proliferation of like this fibrous tissue that's going to cause blockage. Also, destruction of like the intima and the media and everything can make these walls weak, and that can cause those aneurysms, which is like the outpouching aneurysms, which can then burst, right? And so that's a problem as well. They can also have thrombus formation within the aneurysm. So overall, just not a good thing, right? And so this is the most feared complication for patients is just, the cardiac complications of Kawasaki's. And this is just another depiction of that, but okay. And then clinical symptoms and phases. We already talked a little bit about the symptoms, but there are some, the phases of Kawasaki's disease. There are 3. So there's an acute phase, which is about 10 days long. You have the fever and the clinical findings, and you have inflammatory markers systemically, so like on labs. The subacute phase, you still have inflammatory markers present on labs, but the fever usually resolves. And then at this point, you often see like peeling of the hands and the feet. So like all the symptoms are starting to go away, but the patient will start to have peeling of their hands and feet. And then the convalescent phase, like from 3 weeks through 8 weeks, is like going to be resolution. However, you'll still have evidence of inflammation on labs. So inflammatory labs, those are known as like ESR and CRP are 2 types of lab, erythrocyte sedimentation rate, and something reactive protein. Why can't I think of the word? I have it on another slide, but those are 2 types of labs that can cause, that are indicative of inflammation. And I think the important thing to know with Kawasaki disease is that even though it's resolved, these labs can continue to be elevated for weeks. And that's important because if it was something that was caused by like an infection or like entirely an infectious process, we would expect with resolution for those labs to go back down, for there to be less inflammation. So that can tell us that, yes, we do think that this was secondary to this inflammatory Kawasaki's process. Okay, so with a diagnosis, it's largely clinical. And here's the diagnostic criteria. So you have to have a fever for 5 days or more, and then you need at least 4 of the following. So you guys can read through that, but you can see that our patient Keisha had many of these, right? Now, it is a largely clinical diagnosis. It's not a diagnosis that's made based on labs, but you can do labs to help if, like, for example, that the diagnosis is not as clear, it can help the picture more. So some laboratory findings that you see in Kawasaki's disease, if you do a complete blood cell count, you'll often have elevated white blood cells. They can have elevated platelets too, which is called thrombocytosis. A lot of that is because inflammation causes thrombocytosis or causes an elevation in platelet level. Liver enzymes can be elevated, and then the inflammatory markers, as I was talking about with the 3 phases, erythrocyte sedimentation rate and C-reactive protein, or CRP, they're often elevated, and that persists for a while, even after resolution. And then a urinalysis, sometimes you can do that and see what we call sterile pyuria, which is the presence of white blood cells in the urine in the absence of bacteria, because that is coming from like inflammation of the urethra in Kawasaki's disease. So they don't actually have an infection, but you can see this because of the inflammation of the urethra, causing then these white blood cells to be leaked into the sample, and then it comes back as like sterile pyuria. Okay. So our patient meets the clinical criteria for Kawasaki disease. So you decide to evaluate labs as well. They did show leukocytosis, so an elevated white blood cell count, elevated platelets, and elevated inflammatory markers, and she had a normal urinalysis. So what is the next step for her? First of all, do we think she should be admitted to the hospital? Yes. Yeah. So for monitoring, right? This is a serious diagnosis with lots of complications. So it's important for her to be admitted so we can keep an eye on her and so we can treat her. So a couple things. How do we think she should be treated, and should there be any more evaluations? So as a hint, I want you to think about the complications we talked about. Is there anything else then you want to maybe look at, or if you have an idea of how we treat this too, you can also put that in the chat. So remember that the complications are like the coronary aneurysms, potential myocardial infarction. Is there any tests that we can do to look at the heart to make sure it's okay? Echocardiogram, yes, awesome. Definitely, echocardiogram. So all patients that have been diagnosed with Kawasaki disease, they need an echocardiogram at diagnosis. They'll need one follow-up too to see, to compare, but they do need one right away to kind of give us an idea of what's going on. So she should be admitted to the hospital. She should get an echocardiogram. So here's a picture of hers. This is actually a normal echocardiogram. We don't see any aneurysm formation or anything like that. This is the left atrium, left ventricle, right ventricle, and this is the kind of aorta leading into the aorta, which is going to go down and send blood to the rest of the body. But here is an example, of like an aneurysm that has formed in the left coronary artery in a patient with Kawasaki's disease. So kind of this ballooning and outpouching. That's an aneurysm that has formed there. So not a good sign, obviously. But our patient's was normal. Okay, and then how do we treat it? So when we admit them to the hospital, the mainstay of treatment for Kawasaki's disease is both aspirin and then IVIG. So aspirin, if you guys can imagine, like patients who have, atherosclerosis or like, bad hypertension or risk factors for cardiac disease, like adult patients, they're often put on a baby aspirin, right? To kind of thin the blood and lower their risk for having a heart attack, stroke, that sort of thing. So the same principle is kind of true for patients with Kawasaki's disease, is we want to lower that risk of like developing, an MI and all of those sort of complications. And it also has anti-inflammatory properties. Most importantly, the high dose aspirin that's given earlier is the one that's going to help with the inflammation, bringing that down. So we give them a high dose aspirin. And then if you do end up seeing coronary artery changes when they're do a follow-up on the echo, then you might want to keep them on low dose aspirin for a long time, right? But that's at follow-up. And then IVIG, so that's intravenous immunoglobulin. And this is like immunoglobulins from human plasma. Essentially, you're giving the patient antibodies that are going to fight against a broad spectrum of bacterial and viral agents. And so the reason this helps in Kawasaki disease is not only do we think that there could have been an infectious trigger, but this helps bring down the inflammation greatly. So as you can see here, this has actually decreased the incidence of coronary artery aneurysms from 20 to 25%, which is a lot, right? 1 in 4 people getting an aneurysm to 2 to 4%. So definitely need to admit to the hospital and give them this. And then, this is just talking about the dosage, but yes, mainstay of treatment, aspirin and IVIG. And then once the patient leaves the hospital, they'll need a follow-up with cardiology within the first couple of weeks, right? Because we still want to make sure that while they're going through those phases, they're not developing any coronary artery aneurysms and things like that. So they'll have to have a follow-up with cardiology. And then, at that time, it can be decided if they need to stay on, low dose aspirin or not. But that's kind of what it looks like for them as far as like follow-up goes. Okay, well, that is all for today. Kind of a short, I guess, we'll know we're ending on time. But thanks for participating. I hope that was helpful. I think Kawasaki's disease is something, we should all be aware of, just because it's such a scary diagnosis, and it is relatively common, especially in, Asian and Pacific Islander populations. And so you don't want to miss that for sure. If you have a pediatric patient with a fever and a rash, always keep Kawasaki on your differential. Okay, well, you guys can go ahead and do the quiz, and then we'll see you in a couple Wednesdays. All right, thank you.